Hello and welcome to Alexander Disease Research Update, episode number 33, recorded on July 7th, 2026. I'm Albie Messing from the Waisman Center at the University of Wisconsin, and with me today is Ylenia Vaia from the Center for Diagnosis and Treatment of Leukodystrophies at the V. Buzzi Children's Hospital in Milan, Italy. And before we get started, please send feedback and questions to my email address, amessing@wisc.edu. Ylenia, since this is your first time on the podcast, can you tell us a bit more about yourself and how you came to be interested in Alexander disease?
Hi, thank you very much for having me here. It's a real pleasure. I'm a pediatric neurologist at the Boespflug Children's Hospital, as you said. I first encountered leukodystrophies actually by chance during my residency. And one rotation led me to start working with Davide Tonduti and to discover what was then the work of a developing team that over the years has grown into this established center that is the Koala Center. I continued working with Davide whenever I could for the rest of my residency and then came back permanently after I completed my training, and I'm now finishing a PhD at University of Milan under Davide's supervision.
Well, great. Thanks again for being here today. Today, our topic will be a paper with Ylenia as the first author, which has just appeared in the journal Molecular Genetics and Metabolism and entitled Neuroradiological Patterns and Prognostic Implications in Type 1 Alexander Disease. And I should say at the beginning, this is a remarkable organizational achievement. There are 27 authors on this paper from 12 different institutions and 6 different countries. So I know how much effort it must have taken to get everybody on board with this plan. So the background of this is that there's been efforts for a long time to try to classify Alexander disease into different types. For a long time, it's been just based strictly on age of onset with neonatal, infantile, juvenile, or adult. And then about 15 years ago, Adeline Van de Veer and her colleagues, I think I was one of them, presented a new classification, which was termed type 1 versus type 2, with the type 1 patients having a early onset, typically before the age of 4, and a set of symptoms that really related to the distribution of where the problems were mostly concentrated in the frontal part of the brain. And so this is very similar to a classification proposed by Yoshida and colleagues from Japan. Much more recently, an Italian group with Ylenia as part of it has proposed a subclassification of the type 1. And this classification focused a lot on when motor milestones were achieved. You divided type 1 into 4 types, which you termed A, B, C, and D. And these are really very different patterns of how the disease progresses. Obviously, it would be great to know in advance which one would be followed for any given patient. So the way I interpreted the goal of this study was to figure out, is there a way to make use of the initial MRI to make that prediction? Have I described that properly?
Yeah, I would say perfectly. In fact, so our broader goal is to find early hints that could suggest disease trajectory over time. And since we know there's no clear genotype-phenotype correlation in this disease and no current biomarkers, but we thought that perhaps starting from putting elements together, we can indeed build a clear prognostic profile for each patient. And this is part of this broader project and started from the specific observation that in our experience, early MRIs of patients who went on to have distinct disease trajectories were actually different in terms of severity. And so this led us to ask whether these differences were actually identifiable in some way, in some systematic way. Yeah.
Okay, so can you start out by explaining your cohort, which patients you studied and where they came from?
So we identified patients from 8 leukodystrophy centers worldwide. There were 2 centers in Milan, 1 center in Paris, 1 center in Iran, 1 center in Israel, 1 other center in southern Italy, 1 center in Boston, and 1 in Montreal. We only included patients with a molecular confirmation of Alexander disease and that were originally classified as type 1A. So after identifying the cohort, what we did was work with two of our neuroradiologists with over 10 years experience in leukodystrophies. We used a phase validity approach to create an MRI protocol designed to capture the characteristic features of Alexander disease and building on a template of scoring system that had been already developed for other leukodystrophies such as for AH and PMD. It mainly covered four domains that were white matter signal abnormalities, presence of mass-like lesions, contrast enhancement, and atrophy. Though these analyses focused only on the white matter abnormalities. We only analyzed the patient's first available MRI because we wanted to test early predictive value. And that's also why patients with more than 4 years between clinical onset and first MRI were excluded. We held online consensus meetings in which the MRIs were evaluated by our two neuroradiologists that were blinded to the clinical evolution of the patients. And there was at least one clinician from our side, and as well as one clinician and or neuroradiologist from the local institution. Meanwhile, clinical data were collected at each center by a RedCap template that was distributed by us. And the subtype assignments in 1A, B, C, or D was based on our previously published clinical criteria. And that's also why patients with insufficient clinical data were excluded from subtyping. And since we wanted to link MRI finding to clinical evolution, we excluded ones that were not classifiable. Then we used statistical analysis to explore association between clinical variables and outcomes. And we also excluded from the statistical analysis type 1A patients that were only evaluated qualitatively because they were very young at first MRI and due to the physiological lack of myelination at that very young age, we didn't want to score something that was not scorable.
So I have a lot of questions about this. But first, perhaps we should explain what you mean by type 1A, type 1B, type 1C, and type 1D. And that's the subclassification that you published a few years ago. And in fact, Davide was on the podcast number 15 to talk about that publication. But let's just briefly review what type 1A, B, C, and D mean here.
So this is a sort of evolutionary trajectory that we try to define under the broader group of type 1 patients. And what we mean as type 1A would be patients that whose disease starts very early and who do not acquire any developmental milestone. And actually, their exitus is usually very early, usually before 2 years of age. Type 1B would be patients that do acquire some motor developmental milestone, for example, head control or sometimes also trunk control, but do never acquire autonomous ambulation. Their clinical course is usually very rapid. They do regress very early, and deterioration is usually before 5 years of age. Type 1C would be patients that do have a certain degree of developmental delay. They, however, acquire autonomous ambulation, and their clinical course is a bit slower compared to type 1B, and their deterioration usually starts after 6 years of age, but before the beginning of adolescence. And then there is the last type, type 1D. They can or cannot have some degree of developmental delay. Sometimes they just have like a language delay. And they do acquire autonomous ambulation, either on time or with delay, and they're usually stable beyond the beginning of adolescence.
When you designed the protocol for evaluating the MRIs, you mentioned that there are 4 features of the MRIs that were going to be looked at. But for this paper, you only focused the analysis on one of those, the white matter signal abnormalities. Why did you not look at the others as well?
No, we actually did look at the others. We saw that almost mass lesions and contrast enhancement did not have any prognostic value at all. And
Hmm.
also, actually, atrophy did not have any prognostic value. And also, we wanted to take out atrophy because we had the feeling that atrophy was something that should be assessed and that may be a future work. And we thought that should be evaluated like longitudinally.
Okay, so you come up with a score, I believe you called it, an MRI score going from 0 to 5. 0 meaning there were no detectable lesions, and 5 being, how would you describe 5? What does the scale refer to?
So generally, what we saw was that there was the classic anterior posterior gradient. We saw that like frontal white matter was affected in essentially all patients, and what we saw that was that moving posteriorly, like to parietal, occipital, and temporal region, were progressively less frequently involved. And actually, what we saw was that there were some specific of these areas that were statistically significantly associated to higher risk of being associated to a 1B outcome. These areas were the parietal subcortical white matter, the occipital and temporal white matter, the temporal periventricular white matter, and then the involvement of the hilar region of cerebellum and the body of genu and genu of corpus callosum. What we did to create the score was take 5 of these areas, so the ones that were most strongly linked to the 1B outcome, to create this score. So 0, as you mentioned, was not affected, 1 would be affected. And then we kind of split the score by patient and observed that score that were higher than 3
Hmm.
were significantly increased the risk of a 1B outcome. That was the first part of the project, kind of seeing in which patients the score was higher. So we saw that a score below 2 was never present in patients that were classified as type 1B, while a score higher than 3 was very highly associated with outcome 1B.
Okay, so that means you already classified these patients into your subcategories based on your previous criteria. Now you're seeing whether the MRI patterns predict any of these.
Yeah, sorry, exactly. It was like done kind of in parallel. So we had the MRI scoring system with the codes and the subclassification. And then those data were put together by our statistician to kind of create, understand whether there were association between MRI and clinical outcome. Yes.
Okay, so you come up with a very useful flow chart for how to make the decisions at the end. So as you say, if there's a score higher than 3, it's a very high risk of being a type 1B. But then in addition, you looked at I guess it's acquisition of head control. If head control was achieved before the age of 9 months, then which is pretty good, then that you would be a type B. But if you have this high MRI score above 3 and you haven't achieved head control by 9 months, then you're in the type 1A. And that's the most severe of your 4 types. Then you've got this middle group. They have MRI scores of 2 to 3. Then you focus on autonomous ambulation instead of head control. And can you explain that part of the flow chart here? If they achieve autonomous ambulation before the age of 3.5, it means what?
Yeah, so since like the MRI score of 2, 3 was kind of a bit in the middle and could was actually represented by all of the subgroups. We thought that the first step would be understand whether there was the acquisition of autonomous ambulation, since we had already seen in our cohort that it could discriminate between two main groups in our subclassification. So it would discriminate among type 1A and 1B, who would never achieve autonomous ambulation, and
Right.
type 1C and 1D, who would actually acquire autonomous ambulation. So we said, so we have this intermediate score, MRI score, so that's not very informative. So let's see whether we have acquired autonomous ambulation. If we have not acquired autonomous ambulation, we would point towards a more severe end of the spectrum, so 1A or 1B. But at the same time, we want to know whether the patient has acquired head control or would discriminate between type 1A and type 1B. So no acquisition would point towards a type 1A, even with an MRI score of 2 to 3, while acquisition of autonomous ambulation, but no acquisition of of head control, but no acquisition of autonomous ambulation would lead to a type 1B. So more severe end of the spectrum, but less severe than a type 1A. If the patient has acquired autonomous ambulation, we would be on the less severe end of the spectrum. So that would be 1C, type 1C or type 1D. And here we have seen in our cohort that there was just one area that would discriminate at the statistical analysis between these two. And so we would suggest to look at this area that would be the occipital periventricular white matter. And the involvement would point towards a slightly more severe clinical trajectory, that would be a type 1C, while the absence of this involvement would point towards a less severe clinical trajectory, so a type 1D.
So let me see if I understand this. If you have an MRI score greater than 3, then you look at whether or not you've achieved head control by the age of 9 months. If the answer is no, you're really severe end of the spectrum, that's a type 1A. If you have achieved head control, even though you have this MRI score above 3, but you've achieved head control, then you're a 1B. Okay, then we go into this middle group. Well, actually, let's go to the other side. If you've got an MRI score less than 2, and then you look at especially the periventricular white matter, the occipital lobes, and if there is involvement of that periventricular white matter, then you're type 1C. But if that white matter looks okay, you're probably a 1D. And then in the middle group, you're in this MRI score of 2 to 3, you're not sure which way you're going, you focus on autonomous ambulation. If you haven't achieved autonomous ambulation by 3.5, that pushes you into the group that's otherwise would have MRI scores of over 3. It's either a type 1A or 1B. If you have achieved autonomous ambulation, that pushes you in the classification system towards the type that had MRI scores that were actually less than 2, and it's 1C or 1D. So it seems very straightforward when you look at your flow chart. Tell me how you think it's actually going to be used.
Yeah, so of course, it needs to be stated that it has not yet been validated in an independent cohort. And of course, it kind of remains a risk-based estimate, so it will never be a certainty. But in our experience, it has already proven useful in our clinical practice. How we would use it would be firstly in early prognostic stratification, so kind of helping to set realistic expectations with families sooner, and also to monitor patients undergoing disease-modifying treatments more meaningfully. And maybe soon also in kind of clinical trial design, allowing clinicians to kind of stratify patients by predicted severity so that we can compare like with like, making it kind of easier to interpret trial results.
Yeah, I think that's going to be really important for clinical trials. So, what do you anticipate as future research directions for this? Are you going to follow it up?
So first, we would really love to kind of validate this flowchart on an independent cohort, just to see if these results are reliable and if they may be used for future researchers and future clinicians in their both clinical practice and research settings. But also we really want to start using that more broadly and more consistently in our clinical practice, just to give families and parents kind of sense of what to expect. So setting realistic expectation, planning the right support and follow-up, and eventually identifying which clinical trials might the patients fit in, or even not too much or not at that time of the disease process.
I imagine it'll be really important to get other radiologists involved and train them in your scoring system and find out really how easy really it is to do in a uniform way.
We try to kind of give hints to our colleagues and radiologists by putting together a figure with all the different kind of abnormalities. But of course, it may raise many questions, but I feel that's something very common, because also as clinicians we always try to use all these scores that are used in leukodystrophies, and that always raises a lot of questions. So yeah, I think the best is to just gather when there are questions about something that has been created and just discuss that together.
All right. Well, before we conclude, I want to disagree with one statement you made right at the beginning, where you said there's no genotype phenotype correlation in the disease. I think, at least for some variants, we know there is. Of course, I think there are, at last count, over 180 variants that have been associated with the disease, and we only tried to show that there was a genotype phenotype correlation for 10 of those. And for the rest, we just didn't think there was enough information to enough patients to really make that kind of prediction. 2/3 of the variants have only been identified in a single person, so we don't know how consistent they're going to be.
Yeah, no, I completely agree. I just mentioned that there is no clear genotype phenotype, but just because like it's not so straightforward as in other diseases. But of course, I do completely agree that some variants are associated to some kind of disease trajectories,
Right.
and that's something we also try to analyze in our cohort, and that also proved very, very nice and also in line with what you also observed. So yeah, I agree.
So let's summarize then. What would you say is the key message here for patients and families from your work?
I would say that we can now get an earlier sense of how the disease is likely to evolve by putting together our first brain MRI, our genetics data, and a few simple developmental milestones. This, of course, doesn't change the diagnosis, but it kind of helps us prepare together. So, setting realistic expectation, planning the right follow-up, and of course, if we can understand the disease better and hopefully sooner, we can make more informed decision and a clearer path forward.
Great. That's all for today's episode of Alexander Disease Research Update. Thank you for listening, and thanks to Ylenia for joining me today. Our theme song was written by Charlie Allenson, and thanks to Daniel's Fight, our sponsor for these podcasts. I'm Albie Messing. See you next time.